Okay, Sebastian Benzekry is a researcher at Inria studying all kinds of cool models in oncology, like machine learning and AI and metastasis models and much more. Today, he will be talking to us about examples from pharmacometrics studies in math oncology. So take it away.
Okay, thank you very much, Jeffrey, for the kind introduction. Can you all hear me and can you see my slides?
Yep, you're good to go. Okay,
cool. So yeah, so today I'm not going to talk about my usual topics, which are mostly modeling of metastases, but I will more focus on some, I mean, a whole discipline, a whole topic of pharmacometrics and how it is used for mostly for clinical oncology. So okay, so first to introduce myself, so I am now the new head of a new team that has just been created, and which I am quite happy of, because we are gathering, we are trying to do a bit like the IMO in Marseille, and we are gathering together pharmacologists, clinical oncologists, and mathematical modelers together in the same unit. And these are all the people in the team. And so today I'm going to talk to you about some of the studies historically done in the context of pharmacometrics and clinical oncology. So what is pharmacometrics? Pharmacometrics is defined as the science of quantitative pharmacology. So it's basically using and applying mathematical and statistical tools to describe and to quantify processes from pharmacokinetics, which is which you can think of describing the concentration of drugs in the body as a function of time. Pharmacodynamics, which you can think of describing the response or the effect of the drug as a function of the concentration. When you combine PK and PD, you get PK-PD models describing the response, for instance, to more efficacy or toxicity as a function of time. And, more important, even more important than just the models of the processes themselves, of the physiological processes themselves, pharmacometrics, the field of pharmacometrics has spent a lot of effort in developing statistical tools to quantify inter-individual variability and to really address how to personalize treatments and personalize dosing and the dosing regimen based on the realization that there is a in how humans eliminate and absorb and drugs. And this is a schematic representation of this, where you can see that depending on the elimination of the drug, of a given drug by a patient, you can either be, sorry about that, maybe I'll stop my video too. Yeah. You can either be in a therapeutic window where you have good care, or if you eliminate too slowly the drug, then the patient suffer from severe toxicities, which can even go to toxic death. And on the other extreme, if the patient is inhaling fast the drug, then the patient might die from the disease, because the concentration, the drug doesn't even reach an efficacy threshold. So there is actually quite already 40 years old long story of pharmacometrics in oncology, and yeah, it starts with, I think it's already quite interesting to realize that back in 1972, you can find this paper by the pioneer of pharmacometrics, which is Louis Scheiner, where you can see the title of the paper. It's modeling of individual pharmacokinetics for computer-aided drug dosage. So already back in the 80s, the principles of population PK, population pharmacokinetics, were set on and were put forth and used for individualized dosing of drugs in the clinic. And in the 90s, specifically, population PK models were developed for cytotoxic drugs. In the years 2000, there has been some pharmacodynamic models especially for hematopoietic toxicities. Here you can see on the right, a very famous model from Lina Friberg about neutropenia. And in the 2010s, there has been a lot of work on tumor growth inhibition model. This is one of the first models published by Laurent Claret and René Bruno. You have heard about these models by Hitesh earlier today. And these are very interesting tools and very great models that have been shown able not only to describe tumor size kinetics, but also the variability, and even more importantly, to predict survival, which has been used for drug development in predicting phase 3 survival, overall survival, on the basis of phase 2 tumor dynamics. But so for now, I will focus first on the pharmacokinetics modeling, and it's based on, I mean, this quite provocative anti-cancer agents are actually given on a one-dose-fits-all basis, which is sometimes adapted to the body surface area or the weight of the patient, but in still cases as a flat dose. Only carboplatin is given in a tailored fashion. You can see a calculator for carboplatin here. And this can be very much improved using mixed effects modeling. Is a technique where, to address how to model population data, such as the one you have here, for which represent the concentration of a drug as a function of time in a population of patients. From these, you build the typical process consists of building a structural model, which can consist of here very simple linear one compartment model with absorption, so differential equations here. From this model, you could do, what I prefer to do is to have a statistical description of the population based on some fixed effects and random effects with some variance covariance matrix describing the distribution of the parameters in the population. And then from this, you can have a fit at the population level, which is much more interesting, because now you can describe you can describe not only the dynamics, but also the inter-individual variability. And this is very, very powerful, because you can use this as a population prior to perform Bayesian estimation when in the situation where you have only sparse measurements, which is the situation that you have in routine clinical management of patients. For routine clinical management of patients here of TKIs, tyrosine kinase inhibitors in Marseille, we are routinely using these models and some softwares to patient parameters of the models from the population prior and sparse measurements of coming from therapeutic drug monitoring. And you can see the software that was developed and that we use here, where the residual, the Cmin, so-called Cmin, which is the trough concentration, can be simulated. And if it's not in the target area, then we can simulate the proposed dose that would be that is proposed to adapt the scheduling. So this is a bit the process. When there is a new patient with unknown PK parameters, we combine with the population PK prior information. With only one observation, we do Bayesian estimation, identify the PK parameters, run simulations, and predict what should be the next dose for the next cycle, and then adapt dynamically to each cycle the dose that the patient should receive. And here you can see an example of sunitinib in metastatic kidney cancer, where the standard dose is to give 50 milligram flat dose. But after adaptation based on the model, there is 80% of the patients in the clinical hospital of Marseille that have dose modification, with a dose modification ranging from minus 75% to plus 100%. And this dose adaptation actually does result in some improvement of overall response rate. This is the overall response rate with correct exposure at baseline. When there is underexposed with no tailored dosing, then this is the overall response rate, and this is the correction when we correct with the model. Next, in the time I have left, I would like to talk about a second study, which was one of the first example I know, at least, of a phase 1-2 clinical trial that was fully based on a mathematical model for the dosing regimen, and there was also an adaptive part done by an adaptation in the trial. And the goal was to densify the protocol of a combination of drugs, docetaxel and epirubicin, in metastatic breast cancer. And this densification was performed. What the goal was to do this safely, because previous attempts had resulted in toxic deaths when trying to densify the scheduling. So the model was based on the combination of PK models, classical PK models for docetaxel and epirubicin, and PD models, mostly focused on the toxicity, and toxicity here being hematological toxicities quantified by absolute neutrophil counts, which are the counts of neutrophils. And the model here is of the Freiberg is a bit like, it's similar to the Freiberg model. And these are patient data from the trial. And as you can see, the model was able to describe the kinetics of these toxicity profiles quite accurately. And then, so the model was used to optimize the scheduling of the administration of the drug. The parameter estimation was an important part of the study. I don't go too much into the detail, but some previous phase 1 studies were used, and some in vitro cytotoxicity assays as well. And optimization is basically optimizing the average size of the tumor during one cycle. But the most important part, the very important part of the optimization, I don't enter into the detail, but this is the crucial part here. It was the toxicity constraints on neutropenia. This resulted in a significant change of the scheduling of the treatment. So these are the 3 days of administration of the drug between the standard scheduling and optimized by the model. But even more importantly, the results of this clinical trial were quite satisfactory, because the first objectives were to prevent important toxicities, and as compared to previous standard reports, there was 100% of grade 3 at least neutropenia, and 1 death in this trial published in the JCO. In our trial, no lethal toxicities has been reported, and no patient experienced any neutropenia, any toxicity of grade larger than 3. But this was the main focus and the main endpoint of the trial. However, also on the efficacy, we also observed some quite interesting results, where the median survival was very much improved, with a 55 months overall survival compared to 20 months overall survival reported in this previous trial. And go further than just adapting and optimizing the dosing for the first cycle of the treatment, the model, the clinical trial also included the possibility of adapting on a Bayesian basis of adapting the dosing regimen after a first cycle. So these are the data of a given patient for the first cycle. These are the data that are used to identify the parameter estimates, and these are prediction of the models. Here, in this case, the predictions were in line with the observations, and the patient did not require any adaptation of the scheduling. We have also in Marseille have ongoing model-based clinical trials for metronomic vinorelbine in non-small cell lung carcinoma. These are with a model-based scheduling, and another one for combination of radiotherapy and immune checkpoint inhibition. And to finish, I just want to mention a quite large project where we are involved, that is ongoing in our team, which is the Quantic project, where we are integrating large and deep data on patients receiving immune checkpoint inhibitors in non-small cell lung cancer, and trying to integrate and develop mechanistic models. And I used the opportunity to advertise open positions in the team. There is a postdoc position open on this project, and we also have a full research tenure position that is open. So please feel free to contact me if you're interested, or if you want to apply to these positions in the beautiful city of Marseille. Thank you very much for your attention. I hope I am still in time.
That was excellent. Yeah, very impressive work. Yeah, we still have a time for a few questions. So I'll begin with Vahida Vakil's question. How has the toxicity constraint been modeled in the 2016 paper? Is it constrained on the maximum dosage or a toxicity model?
Yeah, that's a very good question. So it's so I probably should have mentioned it, since it is actually a very crucial part here. So there were two toxicity constraints which were not on the dose, or not on the on the input function. There were on the level of neutrophils. There was a minimal value, an absolute value that should not be gone beyond. So that was one constraint, that this neutrophil count had to remain above this value, this absolute value. And there was a relative constraint value where the neutrophil count was allowed to go below this value, but there was a constraint on the time passed below this value. The time passed below in neutropenia had to remain acceptable, had to remain smaller than a given time.
Okay. Yeah, so the next question I have is from myself. I'm curious as to if you can use these mixed effects modeling styles to in real time, or do you always need sort of a retrospective data set to inform your just prior distributions before you start with inputting new patients, I guess?
Well, no, you can do it real time. I mean, basically what you do is you do a first, or you take from the literature. I mean, people report in the literature some study that has been done in a hopefully large enough population where they have a rich sampled patients, and so this establishes the prior, and then this you do it in real time. I mean, this we do it every morning. Joseph Ciccolini, who is the pharmacologist, he's not a modeler, but he's using the software that was developed in the team by Athanasius Iliadis, who was an engineer, but has been working on this since the 80s.
Mm-hmm.
And every day he's using this to predict and to adapt the dose. So in this case, it's online.
Yeah, very neat. Very nice talk again. Very well done. So I guess in the interest of time, we'll move on to the next speaker.